Great. At LLS, our mission is to cure leukemia, lymphoma, Hodgkin's disease, and myeloma, and to for patients and their families. And we do that through funding research. Our over $1 billion mark in research funding over the course of the life of our organization, which is really exciting. We do that through providing support services for patients and financial services for patients and their families. And we also execute our mission through our advocacy and public policy efforts that we're going to talk about today, ensuring that all blood cancer patients have access to quality, affordable, coordinated care. So that's me, and I'm going to pass it off to Megan to introduce herself.
Thanks, Thea. Hi, everyone. My name is Megan Busby. I'm the Senior Director of Advocacy at the International has been around 25 years this year, and we are the oldest organization dedicated to improving the lives of multiple myeloma patients while working toward prevention and a cure. We have 4 areas of focus: research, education, support, and advocacy, which is my area of expertise. The IMF worked in California on the bill. We also head up 2 national coalitions on oral parity legislation. One is the State Patients Equal Access Coalition, or SPEAK, which is focused on state legislation, and the other is PEAK, Patients Equal Access Coalition, which is focused on federal legislation to remedy the disparity between oral anti-cancer medications and IV.
Great. Thanks, Megan. Angela, you want to introduce yourself?
Absolutely. Thank you so much. My name is Angela Blanchard, and I am a partner at Political Solutions. We have had the opportunity to proudly represent the 7 California affiliates of Susan G. Komen for the Cure. And the mission of Komen is to end breast cancer forever. Komen also focuses quite a bit on research and funding research initiatives at the national level, as promoting initiatives at the local level through grants to community clinics and other entities that are sharing our mission.
Great, thank you. And Autumn.
Hi, this is Autumn Ogden, the State Director of Legislation here at the American Cancer Society Cancer Action Network, and we obviously we fight against all different types of cancer through research, but we also here at the Cancer Action Network do this through public policy, and also we fight for access to care to ensure that our across the board.
Wonderful. Thank you guys all for being here. It's great to have you be a part of this. So just some housekeeping items. Again, if you're having challenges with the audio, you can click the meeting info tab and there's all the information there if you get disconnected to call back in. If you have a question during the course of the webinar, there is the chat function. You can just type it into there. My colleague Kim Tice is also here with me, so if you want to just email her directly, you can help me field questions that we'll answer at the end of the webinar. And then I just want to let everyone know that we will be posting the slide deck as well as a recording of the webinar on the Speak website, and I will put this website up again at the end of the presentation, so if you can have time to write it down then. And there's a lot of other great information that I'll talk about a little later that's on that website in terms of this issue throughout the country. So I'm just going to go over sort of what we're going to cover today, and then I will hand it off to Megan to start us off. But we're just going to go over the issue, the national context of this issue, and how it's played out across the country. We're going to have Angela talk about the context within California and the history of the bill here. Komen was the lead organization on this legislation in 2013, so it's been really great working with them as such an integral part of this. Autumn's going to talk to us about who this legislation impacts and also the groups that aren't affected by this legislation and what that looks like in this state. I'm going to wrap us up with talking about if you still think that someone you know or a patient you work with is experiencing copays that are not in compliance with this law. We'll talk about the steps that you can take to address that with the patient that you're working with. So, so I'm going to hand it off to Megan to get started.
Great idea. So just to give a little bit of background on the issue that we're talking about and the issue that the law in California remedies. The problem is that the patients who are taking so there are anti-oral cancer medications and there are IV anti-cancer medications. The oral anti-cancer medications are mostly covered under prescription benefit or pharmacy benefit, which then results in a coinsurance of the drug or a very high copay. So they're paying, as you can see, up to 50% coinsurance on the cost of the drug, which, as many of you know, cancer drugs are expensive, and so this can result in thousands of dollars per month to keep them alive. The IV or injectable anti-cancer medications are covered under a medical benefit, which then results in a lower copay, anywhere an average 15 to 25, maybe up to $50 for their treatment. So there's a large disparity between the out-of-pocket cost to the patient for their oral anti-cancer medications versus their IV or injectable anti-cancer medications. And because of this, what we consider an outdated benefit design, given that anti-cancer or chemotherapy is really evolving, and there are a lot of innovative therapies out there now that are much more targeted and are taken in oral form. We have worked really hard, all of us here that are presenting on this issue in California and across the country. So the next slide will show you that we've actually been quite successful. California joins 39 other states and DC that has passed some sort of legislation that fixes this problem and basically says that if an insurance plan covers chemotherapy benefits or anti-cancer medication benefits, they should cover all forms of that at the same rate, regardless of how it's administered. Or to pass it back in 2008, and then between 2008 and 2013, all of the laws that we have termed pure parity laws, which state exactly what I just said, and it's that if an insurer covers chemotherapy or anti-cancer medication or treatment, it should cover the oral anti-cancer or oral chemotherapy on a basis no less favorable than it does the IV. Then in 2013, Louisiana passed what we call a CAP bill, or it puts a cap into place on how much insurers or how much a patient can be charged for their oral anti-cancer medications per month. So in 2013, Louisiana was the first one to pass this CAP bill, quote unquote. That's not really an official term, it's just kind of what we call it internally. And since then, Utah, Ohio, Oklahoma, Nevada, New Hampshire, Wisconsin, Missouri, Kentucky, Georgia, Florida, and finally also passed, again, the quote unquote CAP bill. They range between $50 to $300 per prescription per month. So they vary a little bit throughout the country, but they're still at least eliminating the cost burden of, or financial burden of patients with cancer across the country. So I'll turn it over to Angela.
Yes.
Great. Thanks so much, Megan, for the overview of laws throughout the country. I would now like to provide a brief recap of our efforts in California and explain a little bit more about the version that we ultimately passed in 2013 and what it does and what it means for patients and improving access to high-quality therapies. So first, I want to thank many of the patient advocacy groups and community leaders and medical providers that were instrumental in helping us to pass AB 219. The support coalition tried and failed with 3 legislative attempts under 2 separate governors before we finally got a bill in 2013. Efforts started back in 2009 with Senator Wright authoring SB 161, and this bill sought to establish parity between IV and oral chemotherapy drugs. This bill was ultimately vetoed by Governor Schwarzenegger, and his primary concern was cost. So the coalition came back together in 2010, again with Senator Wright, this time with a different bill, SB 961. The bill made it all the way through the legislature and ultimately was once again vetoed by Governor Schwarzenegger. And again, his concerns were, of course, cost. And then he also cited that the bill was not necessary in light of all of the federal health care reform that was pending. So we came back again in 2011, this time with Assemblyman Perea leading the charge, and we introduced AB 1000. And what this bill would have done was it would have prohibited a health plan from requiring a copay for an oral chemotherapy drug that was higher than an IV administered drug. This bill was ultimately vetoed as well, and Governor Brown directed stakeholders to work with the Department of Managed Health Care to try and find some alternative solutions. Again, we didn't give up. We came back in 2013, and finally we were successful in passing AB 219. This bill was signed into law by Governor Brown on October 9th, and it went into effect this January, increasing access for thousands of Californians. Now, what does the bill do? The bill does several things. First, it establishes a $200 per month per prescription cap on patients' copays. So meaning if you are on an oral chemotherapy drug, your monthly copay would be capped at $200 for that prescription. Now, for enrollees with high deductible plans, the $200 limit applies after the enrollee's deductible has been met. And this bill also allows health plans to adjust the $200 limit for inflation on an annual basis, and it did have a sunset added to it of January 1 of 2019. And this was because Governor Brown and the administration insisted that a sunset be added, in part because they wanted to see how the bill would be implemented and how it would work. So AB 219 did not create a new benefit, but it simply leveled the playing field for cancer patients. And as you know, as much as 30% of new drugs are now coming in pill form, and we strongly believe that making drugs more affordable and accessible will greatly help patients throughout the state. So with that, I turn it over to Autumn Ogden of the American Cancer Society, who will now explain who this law specifically applies to.
Thank you, Angela. That was a great setup. So this law specifically applies to consumers with state-regulated insurance that are, oh, sorry, you just said that. So it would cover the folks with group plans, individual plans, plans purchased on Covered California or in our individual exchange market, and the health savings account plans. But with the health savings account plans, it will be after the deductible has been met. And I wanted to also point out that while many of you may be aware, this year recently Covered California passed regulations limiting out-of-pocket costs for high-cost drugs. Depending on the plan, it would be between $150 to $500 per month, and it would begin in 2016. But this does not affect the oral cancer drug. This will be separate from what Covered California has recently done. So, and the oral cancer medication, of course, is available now. So I wanted to just make sure that there was that clarity for those who are keenly following the Covered California process. And then as far as who does not get impacted by this legislation, it's consumers with federally regulated health plans, which would include large group ERISA plans, which is the Employee Retirement Income Security plans, Medicare, and state-run health care programs such as Medi-Cal, AIM, and PERS plans. And And that, with that, I will turn it back. I believe Thea is next.
Yes. Thank you, Autumn. So with that, now that you have an understanding of sort of who is impacted by this law, we can start to think about if you work with patients, if you're a caregiver, if you're a patient yourself, whether or not this law applies to you and whether or not it affects it's affecting your out-of-pocket costs currently if you signed a new, reinstated your insurance this year. So to give you some context for how it was implemented, this bill didn't have any regulations, so it went directly from being a legislation into statute. As some of you probably know, California has 2 health insurance regulatory agencies that oversee the whole state-regulated market, the Department of Managed Healthcare and the Department of Insurance. As a general rule, the Department of Managed Healthcare manages HMOs and managed care plans, and the Department of Insurance has sort of the PPO side, but there are exceptions to those rules, and we'll talk about that a little bit later if you're thinking about needing to complain to one of these agencies. One of the challenges of the implementation of this law is that while it was implemented and insurance companies know that there are new they have to adhere to, these departments rely mostly on a complaint-based model to investigate plans. So if they don't get a complaint from a consumer about an issue, they're not going to investigate it within a plan, which is sort of a tricky situation now as there's patients who have been paying high out-of-pocket costs, high out-of-pocket co-pays for their medications for a long time and may not know that all of a sudden this year that copay should be a lot lower. And so we've done a lot of work among this group of cancer advocacy organizations to make sure we're trying to find out if those stories are bubbling up in the community. We actually haven't found anyone that has actually not, that has a plan that wasn't in compliance, but that doesn't mean they're not out there. And so that's really what this webinar is about today. All of you are armed with the information so that if you do hear of a patient who, bought their plan on Covered California and still has some really high copays, you sort of know where to go next. And I wanted to just highlight some information. The Consumer Reports National Research Center did this study this year, and I think it just has some compelling information to think about as we think about just sort of the lay consumer. They ask people sort of about if you get a medical bill that you think is higher than what you should be paying, what are the things that you do? And so what they found is that about 25% of Californians have at some point gotten a medical bill that they thought shouldn't be that high or they thought they shouldn't be paying at all. The majority of Californians don't know the state agency that actually regulates insurance or that there even is one. And then about two-thirds of Californians were unaware that there is even a process to go through to appeal something if you feel that something should be covered and it's not by your insurance. So I just want to give that context to sort of, the understanding of the lay consumer doesn't always know that they have the option of going to the state agency level of complaining. And so if you are, in a situation, if you're a healthcare provider or a caregiver or someone, even a patient who, is part of a patient community through support groups and the medical clinics that you go to, here's some great information about what to do if you do hear that someone has a copay that is over that $200 limit and what they can do to see if that is, an insurance plan that's not in compliance with this law. So the first step is always to go to the insurance carrier and to just check with them, see if it was an oversight on their part or something like that. Once you hit a dead end there and they say, oh no, this is what this costs, that's when you take the next step of filing a complaint with the appropriate state agency. And like I said before, there's 2 state agencies that regulate insurance in California, the Department of Managed Healthcare and the Department of Insurance. Again, it's a little tricky to discern which one regulates your insurance. It does say on your explanation of benefits there should be some fine print at the bottom about which one it is. But as a general rule, I usually tell people to start with the Department of Managed Healthcare. Over half of the covered lives in California are regulated by this department, and I think it's about 20% of regulated lives are regulated by the Department of Insurance. So just statistically wise, you're probably more likely to have a plan that's regulated by the Department of Managed Healthcare. So it's always a good plan to start there. And they're pretty good about shifting people to the Department of Insurance if that's where they need to go to file their complaint. And there's both, you can either call the 1-800 number, there's also online forms. I've helped patients sort of navigate this. They're pretty simple. But again, we'll have our contact information up at the end. If you do run into this issue and want some support in helping guide someone through that process, we're happy to do that. So I'm going to stop now and see if we've gotten any questions. If you still have questions or want to ask, feel free to type them into the chat section of our webinar screen. It should be in the bottom right of your screen, or you can email Kim Tice, and we'll see if we've gotten any questions. So there is a question that Kim received about, the folks that this doesn't apply to, and that's groups like, as Autumn highlighted, federally regulated plans, so Medicare and ERISA plans. So if you have a large group plan, usually it's an employer with more than 100 employees. If you work for an employer that works in several states, you're likely on one of these large group plans. And there is federal legislation in Congress right now to address both the Medicare market as well as sort of the bigger ERISA federally regulated market as well. And we can provide some follow-up information on that if people have questions. We'll have our emails up at the end if you have more questions specifically about these federal regulations. And then we have a question on here about do we think payers will raise their deductibles? That is not something I can predict. I don't have the foresight to do that. We know that there's out-of-pocket maximums that are in the Affordable Care Act that will require insurance plans to only have an out-of-pocket max to a certain level. But, for the most part, I think a lot of, especially I can see for the covered California state-based exchange market, a lot of those deductibles are pretty high already. And so the impact really of this legislation is that $200 cap, unless you have an HSA plan, it applies pre-deductible. So we've talked to patients who they hit their whole deductible in the first month of the year paying for their medications, but now with this protection, they don't have to bump up against that barrier. They just start paying the $200 for their monthly supply starting in January. So it really helps them spread out the cost of their drugs throughout the year. I'm about disseminating the slides. So we are just going to post them on the website. The way our registration worked is we don't have a list of emails for everyone. So I'll advance to that slide in just a second. I'm just going to give people a few more minutes if anyone has any questions.